Good morning, everyone. So today we're going to tackle the pharmacotherapy of rheumatoid arthritis. Now, I could just stand up here and drone on with a list of drugs, right? But pharmacology really comes to life when you see it in action. That's why we're going to walk through a real patient case from the very first symptoms to her current treatment plan. You'll see how we think, how we choose these drugs, and why they work.
So let me introduce you to Helen. She's a 42-year-old nurse who came into my clinic, and honestly, the moment she walked in, the clues were already there. Just look at her hands. This isn't your grandma's osteoarthritis, that wear and tear kind of arthritis. This is different. It's symmetrical, it's puffy, what we call boggy swelling. Then she showed me these nodules on her forearms. When you see that combination, the swollen hands and these classic rheumatoid nodules, your mind should immediately jump to a systemic inflammatory arthritis.
And when we dug into her history, the picture got even sharper. She'd been dealing with this symmetrical pain for about 3 months. But a couple of things really jumped out at me. First, that classic hallmark of inflammatory arthritis, morning stiffness that lasts for over an hour. That's a huge red flag. And second, her social history, a pack-a-day smoker for 20 years. Now remember that. As we're about to see, that's not just some side note, it's a critical piece of the puzzle.
Okay, so we've got a really strong clinical suspicion. The history and physical are all pointing in one direction. But suspicion isn't a diagnosis. How do we prove it? What are the next steps we need to take to say definitively this is rheumatoid arthritis? Well, for that, we need to look at some specific biomarkers in her blood.
Our diagnostic workup really boils down to 2 main types of blood tests. On one hand, you have the general inflammatory markers, your ESR and CRP. You can think of these as the body's smoke alarm. They scream that there's a fire happening somewhere, and they can even tell you how big the fire is, but they can't tell you what started it. On the other hand, you have the autoantibodies, specifically rheumatoid factor and anti-CCP. These are the arson investigators. They point a finger directly at the cause, a specific autoimmune process that is highly suggestive of RA.
And here are Helen's results. Just as we suspected, her inflammatory markers, the smoke alarms, are going absolutely nuts. Her ESR and CRP are through the roof, confirming this massive inflammatory state. But the real smoking gun is her autoantibody panel. She's positive for both rheumatoid factor and, this is the big one, anti-CCP, which is incredibly specific for RA. You take those labs, you add in her x-rays, which are already showing early signs of joint damage, and the diagnosis is locked in.
And I want you to really focus on this point. That high anti-CCP result, it does more than just confirm our diagnosis. It's a crystal ball. It tells us what her future with this disease is likely to look like. A titer this high is a major prognostic indicator, predicting a much more aggressive, rapidly destructive disease course. This isn't just an interesting lab value. It's a clinical mandate. It tells us we have to hit this hard and fast with treatment, right from day one.
All right, so we have our diagnosis, and we have a pretty good idea of the prognosis. Before we jump into treatment, let's take a quick step back and ask the most important question. What is actually happening inside Helen's body? What's the biology that's driving all this destruction in her joints?
It really all begins with a loss of self-tolerance. So in someone who's genetically predisposed, like Helen, an environmental trigger comes along. In her case, it was very likely the toxins from years of cigarette smoke. This creates stress in the lungs, which in turn activates certain enzymes that modify our own body's proteins in a process called citrullination. The problem is, her immune system sees these newly modified proteins and mistakes them for dangerous invaders. This kicks off the production of those very specific anti-CCP antibodies we found in her blood.
From the lungs, this battle then moves to the joints. Those autoantibodies and activated immune cells set up shop in the joint lining, the synovium, and they unleash what we call a cytokine storm, with players like TNF-alpha and IL-6 leading the charge. This creates 2 huge problems. First, the synovium starts to grow and proliferate, forming this invasive, boggy tissue called a pannus. That is exactly what's causing the swelling in Helen's hands. And second, these same cytokines switch on the cells that chew up bone, the osteoclasts, which is what leads directly to those permanent erosive holes we saw on her x-ray.
So now that we understand what's driving the disease, we can start to talk about how we fight back. It's time to map out our initial treatment strategy. Our goal here is to shut down that inflammatory fire as quickly as possible to prevent any more irreversible damage.
You know, the way we manage RA today is completely different than it was a generation ago. It's all guided by this principle called the treat-to-target strategy. This is not a wait-and-see approach. It's proactive. We set a very clear goal, either full remission or at least low disease activity. We measure this goal objectively using scoring tools like the CDI, the Clinical Disease Activity Index, and then we aggressively tweak and escalate therapy every few months until we hit that target.
So, when we're playing by treat-to-target rules, what's our first move? For the vast majority of patients, including Helen, we start with the undisputed anchor drug of RA therapy, methotrexate. It is the cornerstone that we build almost all of our treatment plans upon.
Now, this is absolutely critical to understand. The way low-dose, weekly methotrexate works in RA has nothing to do with how high-dose methotrexate works in cancer. It's a completely different mechanism. In RA, the drug gets inside the cell and it blocks an enzyme called ATIC. When you block ATIC, its building blocks have nowhere to go, so you get this huge buildup of ATP and ADP inside the cell.
So the cell starts to panic with all this extra ATP, and it does the only thing it can. It pumps it out into the space outside the cell. And here's where the magic happens. Once outside, that ATP is immediately converted into a molecule called adenosine. Adenosine is one of the body's most powerful, natural, built-in anti-inflammatory signals. It basically tells all the angry immune cells to stand down. It calms everything down, halting that destructive process and protecting the joint. It's an incredibly elegant mechanism. We're essentially hijacking the cell's own machinery to create a potent anti-inflammatory state.
So, we started Helen on methotrexate. We monitored her very closely, titrating up the dose. But when she came back for her 6-month follow-up, it was pretty clear that methotrexate alone just wasn't going to be enough. Her disease was still simmering, still unacceptably active. It was time to step up her therapy.
And this is a perfect example of treat to target in the real world. We calculated her CDAI score, and the number told the story. She was nowhere near our goal of low disease activity. Her joint counts were up, her inflammatory markers were still high. The data was telling us, loud and clear, we had to do more.
So the next question is, do we switch drugs or do we add one? We add one. And there are two incredibly important reasons for this. First, you get amazing synergy. You have the biologic drug directly blocking a cytokine like TNF, while the methotrexate is working through that totally separate adenosine pathway. It's a true two-pronged attack. And second, and this is crucial for long-term success, these biologic drugs are big proteins. The body can see them as foreign and develop antibodies against them, which makes the drug stop working over time. Methotrexate helps prevent that from happening, protecting the biologic so it can keep doing its job for years to come.
For Helen, our choice was to add a TNF-alpha inhibitor, which is the most common class of biologic drugs we use. This category includes drugs you may have heard of like adalimumab or etanercept. But, and this is a huge but, these drugs come with a major safety warning. See, TNF-alpha is essential for our immune system to wall off certain infections, especially tuberculosis. So before you ever write a prescription for one of these, it is an absolute non-negotiable requirement that you screen every single patient for latent TB to prevent a potentially catastrophic reactivation.
And so Helen's current regimen is this combination therapy. She stays on her weekly oral methotrexate, and on top of that, we added adalimumab, where she injects herself just once every other week. This dual mechanism approach has finally been able to get her aggressive disease under much, much better control.
Helen's journey really does a fantastic job of illustrating the key principles of how we manage RA in the modern era. So let's just take a moment to distill this down into the big picture takeaways that you need to carry with you into your own practice.
First, early diagnosis is everything. Damage starts on day 1, so we have to be faster. Recognize the signs and use your biomarkers. Second, always treat to target. Be proactive, be data-driven, and don't settle for good enough. Third, methotrexate is your anchor. You start with it, you build on it. Fourth, escalate your therapy logically. When methotrexate isn't enough, add a biologic to get that synergistic effect. And finally, never ever take your eye off of safety. You must screen for infections before you start, and you have to monitor labs regularly for the entire time they're on these drugs.
And just to hammer home that safety point, I want you to look at this. The risk of serious infection is real, but it's not the same for all drugs. As you can see here, when you move a patient from a conventional drug like methotrexate up to a biologic, you roughly double their risk of a serious infection. This isn't just a number on a chart. This is the core of your informed consent discussion with your patient, where you have to balance the incredible, life-changing benefits of these drugs against these very real risks.
And that really brings us to our final thought for today. We have an amazing arsenal of powerful therapies for RA now, tools that we could only have dreamed of just a few decades ago. The real challenge for your generation of physicians won't be having enough drugs. It'll be moving beyond this somewhat one-size-fits-all approach. The big question we all need to answer is, How do we get smarter about picking the right drug for the right patient at the right time to truly bring personalized medicine into rheumatology? Thank you.